All right, we are going to begin the webinar now. So good afternoon, everyone. My name is Anna Duncan. My pronouns are she, her, hers, and I'm a program coordinator here at the CoLab for Community and Behavioral Health Policy. On behalf of our team, I want to say thank you so much for joining us for this webinar. This is our third and final installment in a three-part webinar series we're hosting on pediatric integrated care. And before we begin, we will start with a land acknowledgement. CoLab for Community and Behavioral Health Policy and the University of Washington acknowledge that there are 29 federally recognized and 7 non-federally recognized tribes within Washington state. Within Seattle and where we are located, we acknowledge the Coast Salish peoples of this land in Seattle, indicated in purple, the land which touches the shared waters of all tribes and bands within the Duwamish, which is indicated by the gray and black, the Puyallup and Squamish in blue, Tulalip and Muckleshoot in yellow nations. As we move forward in advocating for and moving toward health and racial equity, let us remember that we are living in a history-driven present. Let us learn more about the histories, cultures, and traditions of Indigenous peoples and how we might build relationships with sovereign tribal nations and create more inclusive spaces that foster innovation, collaboration, and empowerment. We encourage you to consult nativeland.ca to learn more. Next slide, please. So before we begin, I'd like to do some brief Zoom housekeeping. So if you encounter any technical issues during the webinar, please feel free to just send us a message during the chat box, which is highlighted below in red. We will also have a Q&A session after the presentations, where we'll kind of cover a lot of our content related questions. So if you have a longer, more content focused question, please add that into the Q&A box, which should be at the bottom of your screen. And please note that you are also welcome to use the chat throughout, but we're ideally going to be answering questions through the Q&A box. Also, as a reminder, we will be recording this webinar and it will be uploaded to our YouTube and our website. Next slide, please. So this webinar series is approved as a CME credit provider through the American Academy of Family Physicians. And you don't have to attend all 3 webinars to receive credit. You can do them in an a la carte fashion and receive, credit for 1, 2, or all 3 of them. And if you're interested in receiving credit for the previous 2 webinars, they are uploaded on our website. So you're welcome to just watch them retroactively and then submit for credit on their website. And to give a little bit more context on CME, for AAFP members, you can just self-report this credit directly with them. And for those who aren't members of the AFP, please check in with whatever entity you typically report your CME credits to ensure that they actually accept this credit. Additionally, also happy to provide a certificate of completion if you're interested, or if you have any questions, we're happy to answer those. So feel free to email us at uwcolab@uw.edu. Next question, please, or next slide, please. At the end of the webinar, we will send an evaluation survey link through the Zoom chat, and this should also be emailed out to you automatically as well. So we'd love to hear your feedback on what you liked about the webinar and also improvements that you might like to see for future webinars. And we'd also love to hear if you have particular topics that you'd like us to focus future webinars on, particularly around mental health and public health related disciplines. Okay, next slide, please. And before I turn it over to our presenters, we're going to take a quick look at our live poll results. Thank you, Joanne, for sharing those. So it looks like we have majority of folks are from the mental health care field, but we also have a lot from general health care, academia, physicians, and then direct service. So it looks like we have quite a range of folks in kind of the mental health, public health sphere. So thanks so much for answering that. It's really helpful to know who's in the room with us today. If we go to the next slide, please. Thank you. So again, I just want to thank you all for being here before I hand it over to our wonderful presenters. We at the CoLab for Community and Behavioral Health Policy are really excited to host this webinar series and to have you here today. And as previously mentioned, this is the last of a 3-part webinar series focused on integrated care and what we can learn from this exciting healthcare model. And for those of you who are joining us for the first time, the CoLab for Community and Behavioral Health Policy was founded in 2020 within the Department of Psychiatry and Behavioral Sciences at the University of Washington. The collab engages community expertise and research evidence to spark creative and sustainable change in behavioral health policy and systems, particularly systems involving youth and families. We believe communities and systems have deep knowledge and expertise that must be leveraged to promote effective, sustainable, and impactful community programs and strategies. If you're interested in watching other webinars that we've done in the past, or just learning more about our work, please feel free to visit our website at uwcollab.org. So transitioning to today's webinar, we're really excited to have two wonderful speakers, Dr. Erin Shainfeld-Gonzalez and Dr. Nat Youngblood. And I'll let them tell you a little bit more about themselves, but briefly, Dr. Gonzalez is a practicing clinical psychologist at Seattle Children's Hospital and an associate professor with the University of Washington School of Medicine. Dr. Youngblood is a clinical psychologist serving as a trainer, consultant, treatment developer, and researcher at Seattle Children's, Harborview Medical Center, and University of Washington. And now I will hand it over to Nat to begin their presentation.
All right. Welcome, everyone. And I'm excited to see some names I know and some names I don't know. I'm just going to share my slides here in the participants. And Erin and I are so excited today to have a chance to talk with you about the First Approach Skills Training, or FAST programs. While we are the leaders of the FAST effort, and while we're the presenters today, we're part of a much larger team, and we'll share a little bit more about all the many people who have contributed to make FAST possible. Just a quick note about disclosure of funding. So we have identified no conflicts of interest related to the work that we'll talk about today. And actually, we want to point out that everything that we'll talk about is free, which is always fun. All the treatment-related resources and materials are freely downloadable at our website. And all of the live training and case consultation is provided for free if you're an integrated behavioral health provider, if you're part of a integrated primary care setting. So, and also acknowledging that the FAST work is funded by the Healthcare Authority of Washington. So Erin, do you want to say anything else about your funding?
Sure. Yeah, I have external funding from NIH, and in the past have done some consulting for a smartphone app.
Cool. And I do this work, the FAST work, as an employee of Seattle Children's Hospital. And I also have contracts with Harborview Medical Center, where I help lead the CBT Plus training initiative for Washington State, and also with the SMART Center at the University of Washington, and have received funding from NIMH. So let's dive right into the FAST programming. And our goals with FAST are really to empower primary care providers and primary care clinics, especially to manage mental health. And we know that you all are doing that already in a big way, especially now. And we want to provide the tools that can help you do that effectively and feel effective in that work. We are really striving to create access to meaningful brief treatments. And we're especially excited to be creating access, we hope, for folks who, for reasons of may it be stigma or financial or systemic barriers, just aren't accessing the care or can't access the care as readily otherwise. So we're hoping that FAST can be part of an effort to reduce disparities when it comes to mental health care and outcomes. And we're eagerly adapting evidence-based practices to the realities of primary care, and we're going to highlight some of the ways that we're trying to do that. And we've aimed for hyper-efficiency in our training approach as well as implementation, because we really want to preserve, we know that mental health resources are limited. We know we're trying to create access in primary care. And one way that we can do that is to really reduce the amount of time it takes to implement, right, to prepare for and deliver these treatments, as well as to learn them. So at this point, we have 4 programs that we're supporting around the state, including FAST Anxiety, FAST for Child Disruptive Behavior, FAST for Depression, and FAST for Parenting Skills for parents of teenagers. And in development, we have a couple of programs in the pipeline. FAST Trauma is very close to being available. We're just on the cusp of piloting it. And FAST Safety is in development. And these are briefer versions of evidence-based treatments that are longer. And we've designed them to be a first step in care and stepped care a stepped approach to care. And this is appropriate for settings like primary care or for settings like school and other settings where maybe you have limited mental health resources that you need to use wisely. You're trying to create access, and you also aren't trying to recreate the sort of tertiary level of care, right? Because it's not practical. So we're hopeful that these brief interventions can be helpful either as first step in care or as a bridge to a higher level of care if you're in a setting where that's important. Okay, so I want to start with an example. And this case example comes to us from our colleagues at Hope Sparks and Pediatrics Northwest. I think this one specifically from Jacob Cowan, who's a wonderful colleague of ours, and his name's going to show up again later in the presentation. But this is just to illustrate what we mean by brief, meaningful treatment. So this 13-year-old male presented with OCD symptoms of excessive hand washing, and unplugging electronics, switching lights on and off, checking locks, closing and checking blinds. And following an intake in just 9 brief sessions, about 30 minutes each, the concerns had resolved. And the parent reported that they'd stopped accommodations like watching things unnecessarily to reduce the teen's anxiety. And they noticed the family was going through much less hand soap and detergent. The parent pointed out that the teen goes to bed easier and now gets a full night's sleep. And the teen showed the provider their hands, which were healing and were no longer dry and sort of suffering from the excessive washing. And that the teen was reporting that they weren't getting that icky feeling that had been so pervasive before, and that it wasn't even happening now. And the scared, which you'll probably recognize as a measure of anxiety, doesn't even measure OCD symptoms. But of course, you can see some elevation, and the score dropped precipitously with this brief treatment. The parent reported that anxiety used to control everything he did. We now have the tools to handle this. I didn't know what to do before. I'm not worried anymore because I know what to do about it. And we have a plan that we can use if anxiety were to come back. So just an example of what can be possible when we provide families, youth, and their caregivers with some evidence-based skills in a primary care setting that some can really benefit in a big way. So why fast? Well, we know that full-length EBTs aren't feasible in primary care. We're trying to create a lot more access than that. And we know that access to specialty care is slow, if at all, and that even when access could happen, a lot of times it doesn't for lots of different reasons. That referral, the bridge to a higher level of care falls apart, and that connection isn't made. And we hear from our primary care partners, we're hearing that they work with really a wide range of acuity, and that they have needs to support kids certainly early on in the mild to moderate range, but also they're having to bridge care for folks with higher severity into higher levels of care. That they have lots of varied parameters that they operate under, that they may have 20 or 30-minute sessions, or maybe they have 60, but it's variable. And also that their ability to do in-depth evaluations is not high. So they're doing brief intakes that are appropriate to this sort of lighter level of care, and that needs to be considered. And also that therapists in these settings in primary care have a wide range of experience. Some are well-seasoned and they've got lots of experience with evidence-based approaches, and others are brand new, right? They may not even have worked with kids and families before, so they're needing maybe more support. And overall, this desire for flexibility, right? Can we have some tools we can use in flexible ways, and that are, maybe we can pull pieces, or we could pull modules, we can sort of flex them around and use within different parameters of care, right? Different numbers of sessions or lengths of sessions, and also with really not a lot of prep time, right, in these settings. So these kinds of sort of feedback really drove our efforts. So let me talk a little bit about the adaptations we did make to make these to make our interventions primary care ready. So the first is brevity, right? We had to make these things brief to preserve access, to really preserve the limited mental health resource for as many kids as possible, and also to try to have providers be more available, right? So they wouldn't be always sort of shut in a room seeing families, but that they would have just more availability for families and also to consult with providers. So all of our programs can be delivered in as few as 4 sessions, and actually even fewer sessions, because a lot of providers will use even just parts of our programs in a lighter touch way when that feels appropriate to them. But our programs are flexible. And in fact, most programs that we work with, most primary care clinics don't have such tight parameters. Maybe they're seeing families for 6, 8 sessions, but generally in the 2 to 3 month range, I think, is what they tend to be aiming for. They are short, they're flexible, they're adaptable to different chunks of session time. And we've tried to make them very easy to use for primary care providers and for behavioral health providers. That what we settled on was really to try to make worksheets and handouts and workbooks that you just open up and read together. Everything you need to know to deliver a high quality intervention with fidelity is right on the page. You just read through it with the family. In many cases, no preparation at all is required other than to open it up and to be familiar with the materials, but you're not having to refer to a treatment manual somewhere else. You have what you need in front of you. And that guarantees fidelity to the core components of the model. And again, it reduces the sort of pulling providers. It maximizes the time that providers can be seeing families versus preparing, and reduces that burden that's typically associated with evidence-based practices of having to prepare. The other benefit of making these things, and we've worked, as you'll hear, really hard in using user design strategies and lots of iterations, lots of stakeholder feedback to make these tools as intuitive as possible. So they really do, they are easy to use. And one of the benefits is that, as we'll talk about, the training needs should be less. And ideally, we can do task sharing, right? That right now we're typically working with master's level mental health providers, but there's no reason why many of these tools couldn't be used by other staff in primary care settings, because we've tried to make them really straightforward. Okay, and then the other thing is that we're not precious about the handouts, right? So while we've tried to make them hopefully a tool that people will keep coming back to because it works so well, we recognize that over time, maybe you'll find as a provider that you have a different way you like to explain something, right? Or maybe you want to convey exposure or activation concepts, the core components that we really hope that families can get access to. If you want to explain those in a different way, or the family in front of you doesn't sort of really want to look at a worksheet or lots of words, or you have a different maybe way of adapting those resources to the family in front of you, by all means do it. So really lots of flexibility is what we've striven for. We also have really prioritized engaging caregivers and parents for a few reasons. One, in primary care, they're often there, right? In many cases, they're bringing their kids because they're concerned and they want to be involved. And developmentally, they should be involved, right? So we try to involve them. And by involving them, we hope our treatment effects more efficient, so that we won't have to meet as many times, right? Because the parents are working on things between sessions. We also can discontinue care quicker, right? Because hopefully, even if you haven't fully resolved the concerns, we know the family, the parents and the youth will continue working on this, right? So you may say, okay, follow up with me in a month, or maybe just call me if you need me, or maybe you've got it, keep going. And so we hope for efficiency, but also durability, because we know that so many of these concerns are likely to come back across the course of development, right? Anxiety is likely to show up in different forms over time. Depression is likely to recur. So making sure that we empower the family to have the tools as much as possible serves lots of different goals. So we have really tried to streamline to core components. There's lots of great things you can do with families, but where the evidence base allows us to really prioritize, for example, in treating anxiety, we focus right on exposure, right? And with depression, we prioritize activation. And these are, we've chosen them because of the research evidence, because of trying to make our treatments really efficient. And I guess that's the main thing I wanted to say. The other thing is that we've recognized that there's not an in-depth evaluation in many cases. And so we've tried to make our programs robust to that, so that even if you don't have a crisp DSM diagnosis or have a lot of time to evaluate, that as a first entry into care, this can be a warm welcome and appropriate for most kids who present with these core concerns. And we focus strategically on the most common mild to moderate concerns, recognizing that in many cases you are holding more acute versions of these presenting concerns, that you may use this as a first step as you're bridging care. But that what we're hearing from our partners across the state in these settings is that when you take on the most complex, the most acute cases, sometimes that leads you to use more resource than you intend to on a family. So that we have tried to shape our tools and our support in the direction of mild to moderate where possible. Okay. This is intended, though, to be a sufficient dose of treatment for kids, even with clinically significant mental health concerns. And in many cases, exactly those core components that we're training in these treatments are the same ones that they would get in a higher level of care or an intensive setting. They're just packaged in such a way that you can do them briefly. But if you have a family in front of you, and if you have the resources they need to do a more intensive version, you can use these materials oftentimes in that way and provide more support, or sort of rinse and repeat with exposure, for example. You can just keep seeing a family if that's an option or if that's desirable, and use these same tools to provide a higher level of care, if that's an option. Okay, so what this leads to, all these efforts that we've done, helps us to be really streamlined. So because our tools, we've aimed to make them so intuitive and require so little preparation, we have been able to reduce our training, right? Because the information to do this treatment well is on the materials. So we have, for all of our programs, an on-demand 2-hour pre-recorded training that you can access. We'll show you where it is on our website. It's available now. And many providers who want to get started with these tools or just learn about them, you can watch those videos on your time and get started. In the videos, we talk about the target, whether it be anxiety or depression or behavior problems. We talk about how to conceptualize it, what's going on there, how to assess for it, and then how to treat it. And then we walk through each of the treatment materials that we provide on our website and show you just how to use them. So you actually have what you need to get started. Then we offer a live training. And so when we do the live training, we require people to have watched the pre-recorded version to just make sure that our live training time is really brief, right? It's just 2 hours. It's provided via web, so video conferencing. And this, again, minimizes disruption to your resources in your clinic, right? So that providers can get this training without having to miss a day of clinic. The live training includes lots of hands-on practice, troubleshooting of common concerns, Q&A, and just interactive learning goodness. And then following that, we have ongoing case-based learning. So this occurs, again, televideo conference every other week over time. And we have the way that we've tried to do this, you can see we're trying to minimize disruption to your clinic and trying to put our training resources really smartly where they're best used. So rather than doing a really heavy, intensive workshop that takes a lot of time in the beginning, we spread out that precious training resource, right? We want to make sure that our training resource is actually happening where your providers need it as they begin to do the treatment. And then as they encounter problems, we're there. So we're trying to minimize the front end, minimize the disruption, and put that training support in a place that can help them learn on the job. Okay. So I'm going to turn it over to Erin for this next part.
Okay, thanks, Nat. I'll take over the screen share here. That sound good? Okay, I'm just going to override with my screen share. Where is it? There we go. Okay. Let me know if that's not showing up. Should look like what Nat was just sharing. So we wanted to give you a little background on the process of developing FAST. This started as a funded program through the Partnership Access Line at Seattle Children's Hospital, headed up by Dr. Bob Hilt. And this was funding that was provided from the Washington State Legislature and was allotted, and the Healthcare Authority, and was allotted to help find ways of supporting primary care doctors in less resourced regions of Washington State, managing mental health concerns in their clinics. So our first pilot was done in Benton and Franklin County, which in the Tri-Cities, as you know, is far from a lot of specialty care. And we started with developing fast depression and fast disruptive behaviors, thinking those would likely be the two most common concerns we'd see through primary care. And so this pilot was a regional resource model where we were not fully embedded. What we did was trained several behavioral health service providers who were already providing therapy in a couple of community mental health clinics in the Tri-Cities. We trained them in these two models, and then we created a rapid referral pipeline and disseminated information to primary care clinics, asking PCPs to refer kids who they thought needed therapy for depression or disruptive behavior disorders. Those referrals were very quickly able to be triaged to our clinicians. Families typically got a call within about 48 hours of being referred, and then were provided rapid access to therapy with those trained clinicians in their community. And we were strict about just offering them 4 sessions. Occasionally, we offered a 5th flexible session as needed. And so what we found was there was a lot of enthusiasm when we rolled this out in the community. We got feedback from providers, families, clinicians that this was much needed. We did a lot of outreach efforts. This was across a 2.5-year period. And we would see some little bursts of referrals after we did outreach. Our clinicians, our therapists visited primary care clinics. We gave CME conferences, we did mailings, we did email newsletters, but we still had capacity left over in the program. We were prepared to serve more families than were actually referred, although we were referred over 200 families during the course of this pilot. Not all of them connected with our therapists or were able to participate, but we did reach out to them all. And so at the end of the pilot, although there was a lot of variability in how well we were able to engage different families, we were able to find some statistically significant improvement in some of our standardized outcome measures. So we saw significant improvement after just 4 sessions in disruptive behavior reported by caregivers, in functional impairment, so problems related to behavior at school, at home, in social settings. And then in the depression pathway, caregivers reported noticing an observable difference in their teenagers. And again, this was a relatively small sample in some of these subsamples. So we did find some really promising trends in other outcome variables as well, but just weren't fully powered to look at very robust clinical outcomes. But perhaps more importantly, the families who completed our outcome measures were very enthusiastic about the program. All of them reported, everyone who participated reported they were glad they did, they thought it was helpful, they would recommend it. The majority of the families who participated felt that their needs were met by this brief therapy. And that was very encouraging to us to know that we could actually be useful in 4 sessions. With what we noted was that the disruptive behavior track tended to be more likely to say, that was enough, we got what we needed. In the depression track, we found that primary care physicians were referring a lot more highly acute teenagers compared to in the disruptive behavior pathway. So the majority of the referrals we saw for depression were teenagers with really significant depressive symptoms, suicidal ideation or behaviors, self-harm, and a lot of complexities. So our depression track was more likely to say, yes, we want to continue, we want more services, but there certainly were families whose needs were met by the very brief 4-session program. And our clinicians gave us very positive feedback as well, that they felt this was relatively easy to learn. We had experienced and extremely new clinicians participating, and they all felt they were able to get up to speed and that it helped, and that they found the materials and the training and the ongoing consultation with us to be useful. So I've touched on some of this. What did we take away from this? Lots of points that led us to our next pivot. So we found that it was harder than we thought it would be for primary care clinics to identify kids with this kind of mild to moderate mental health needs. They were able to find the kids easily that had severe mental health needs, but the mild to moderate range may have flown under the radar, and that routine screening might have helped with flagging kids earlier who could benefit from therapy. And we often got families with a lot of complexity beyond what even they had talked about with their primary care doctors. And we had talked about different ideas of trying to co-locate in these primary care clinics, but honestly, as many of the folks know on this call, things move really fast in primary care, and asking primary care docs to fully assess mental health concerns, triage them, get them to an external referral location, and motivate the families to follow through. That was a very tall order. And so we needed to be able to support them better in doing that. We did find that we had better connection rates with this community resource model than other previous trials of trying to improve connections between primary care and regional community mental health care. So it was encouraging, but it still was certainly not enough. And of course, we were excited by the findings that clinically there was improvement related to these very brief 4-session programs. So we, at this point, pivoted toward figuring out how do we integrate these programs into primary care settings rather than having this step of referring families to outside resources where we lose a lot of people. And for those who want to read more about that, we had a paper that came out in Psychiatric Services early this year that'll tell you all about what we found and a lot of the limitations of the study as well. So when we wrapped up the pilot in 2018, again, it was clear to us that we needed to better integrate with primary care settings. So we pivoted to partnering with clinicians who were embedded in primary care clinics across Washington state. For most of the clinics, this was a fairly new program that they had just begun to offer, and they're looking for some tools for clinicians and kind of models of care. So we were lucky enough to connect with awesome therapists across the state and began having, we had some trainings that were, some of them were virtual, some of them were in person. And we invited clinicians to join our biweekly case consultation calls, which we are still running. And many of those original clinicians are still part of our calls, which is really fun. And we started collecting implementation and feedback data about our trainings, our tools, and how people were using the programs. We also had heard loud and clear from the original pilot that we needed an anxiety program. There were a lot more anxiety referrals than we anticipated, more even than depression referrals, to our surprise. So Nat Youngblood has led up the development of the FAST anxiety program, and that was developed with a really innovative user-centered design approach. And with all of our programs, we began using kind of an iterative approach to modify them based on our relationships with the integrated mental health providers who are actually using them. And so we were able to update and kind of pivot toward more of a workbook format. I'll tell you in a second about some of those changes. We want to give a shout out to our wonderful stakeholder advisory committee. These are embedded mental health clinicians across the state, as you can see from different clinics. And most of these providers have been with us since for a couple of years now. We've added some along the way as well, but they've been invaluable to helping us shape these programs and making them more useful. And then a lot of organizations have been wonderful to work with and giving us feedback, using programs, and initiating some research in some of the instances. So here's a list of organizations that we have now done trainings with or partnered with in other ways. And most of these are places that are now offering the FAST programs. And we have a few co-authors of the manuals we also want to acknowledge as well. All right, so we're continuing to conduct research on our programs. So again, it happens all the time that we decide we need a bonus module, or we need to tweak something or change something based on our stakeholder feedback or based on needs that are brought up. We'll give some examples of that when we talk about the individual manuals. And several clinics are evaluating the use of FAST, including Hope Sparks and Pediatrics Northwest. The SCCN network is partnering with FAST. There's an R01 with Kaiser Permanente that's using FAST. And we just completed a pilot trial of the FAST Parenting Teens program, which is relatively new through SCRI. And outcomes will be out shortly for that. And then Matt has been using FAST-T, a school version of FAST-T that is being evaluated in a multi-state R01. And we have some other plans for further evaluation grants in the works. All right, Nat, I'll turn it back to you here.
Okay, catch up. So I'm just going to talk a little bit about how FAST can work in your setting. So here we go. Oh, that's better. How it might work is that in the course of providing primary care, there we go. In the course of providing primary care, hopefully doing some screening or at least uncovering some behavioral health concerns, you may find that there is some behavioral health concern present in a family that you're meeting with. And then the next step would be to provide some education. And we'll show you some 2-page educational tools that give basic information about the area of concern, whether it's anxiety or depression or behavior problems or trauma, as well as some really truly actionable strategies that youth and caregivers can use to begin working on this. And this is designed to be its own first step in care. It can be all you give, right? The primary care provider or whoever it may be can say, here, take a look at this. There's some strategies, give it a try. Maybe meet with me in a couple of weeks and we can see how it's going, or maybe just tell me if you need more. Or in some cases, it may be clear after a couple of weeks, or even in that very same visit, that this family could benefit from some more support. And so at that time, they can refer to an in-house FAST provider for one of the programs, or refer them to someone in the community for more support. So that's a little bit of the flow. I want to show you now quickly our website, so you're familiar with how to access our resources. Okay, oop, that's not right. Our slide looks like our website. I just open up our slide again. Okay, here we go. So this is our landing page for the FAST program. You can see at the top, there's a description of FAST. There's a video that talks, I think it's 20 or 30 minutes long, talks about how to integrate FAST into your primary care, including things like screening and how it would flow. There is our training page, which I'll come back to because it has our training videos and other things. But now I want to show you our program materials. So each of them has sort of a little description as well as the materials. And for each program, you'll see a 2-page educational handout that you can access. In most cases, our materials are available in English and Spanish. Some of them are still in the process of being translated. And you can see that we also have workbooks or handouts. And FAST Anxiety, we have a child version of the workbook and a teen version, which was one response to the feedback that we were getting from our stakeholders and our sort of user design efforts. And while we put some ages on this is flexible, and 7 is roughly when maybe reading would be easier for kids. But really the same concepts for FAST Anxiety apply throughout the age spectrum, right? Even into adulthood, it's the same kinds of concepts. So it's really quite easily adapted to younger kids if needed. We've got some standalone handouts related to the programs. Like, for example, we have a needle phobia handout that can be used in a standalone fashion. We have some of those here on the page. This is the FAST B program with, again, the 2-pager and the workbook materials. We've got FAST D, which has, again, the 2-pager, a workbook, and some other things. We've got FAST P, and then we have a placeholder for FAST T and FAST S. And then some other standalone sort of resources, like there's a worksheet for teens about managing their relationship to technology. There's a worksheet for parents of kids to talk about managing screens and devices and challenges related to those. There's then information about our team and the stakeholder advisory committee that we just mentioned. And then at the very bottom of our landing page, I want you all to see that there are assessment tools that you can access. And we have settled on a sort of a set of assessment tools that we've selected for a few different reasons. Certainly, we care about evidence and the fact that they are valid. They've been used with diverse populations. They've been used in primary care, that they are brief, they're free, they're easy to administer and to score and interpret, that they are easy to use and hopefully sensitive to change over time. So that, unlike some screening measures where there may not be a lot of anchors, right? Never, sometimes, often, or that maybe the window of time is 2 months or something like that. These tools are picked because they should work for repeated measurement, which we think is really important. And each measure we've selected for some constellation of these kinds of things. Some have more evidence than others. In any case, you can access them here. We don't in any way prohibit or discourage providers or clinics from using other tools. The really key thing is that we encourage you to use standardized measures to do screening, to do measurement-based care and repeated measures, to use measures in ways that I'll talk about in a moment to help with your initial assessment and streamline that. But again, different clinics may have different tools. These are just the ones that we like the best. And you can see some additional measures related to other areas. But this is kind of the core set of measures, and we encourage a trauma screening for all kids who are presenting with behavioral health needs, because we think that understanding the potential role of trauma or adversity that may benefit from specific attention clinically is really important. Okay, so let me show you the other part of our website, which is the training section. So if you click on training opportunities, you'll see this is where we have our free on-demand asynchronous training videos. And each of them, again, talks about the area, the target of concern, how to think about it, how to assess for it, and then walks through each of our materials and how to use them. Then you can contact us for the interactive trainings and the case-based learning. Okay, so that was it for the website that I wanted you to see. And back to our slides. Okay, so in terms of assessment, again, we encourage the standardized screenings because they help us do brief assessment and they help us have more confidence in our selection of treatment targets. They help us remove bias and also elevate the perspective and voice of our youth and our parents and our families, right? These are the things they're reporting, and we can reflect those back to them, and then we can arrive at some agreement, right? Based on what they're telling us, we can explore what it is that they think they most want help with. We also encourage the top problems approach that Dr. Elizabeth McCauley was describing a couple of webinars earlier in this series, which is really just interviewing and understanding what the priority problems are that the family reports, which will hopefully line up with the standardized measures, but they may not. The final thing that I just want to highlight again is just the measurement-based care approach. So over time, you want to re-administer these scores to determine whether you want to step someone up in care, whether you might want to add a medication or other kinds of treatment-related decisions. And also to facilitate communication within your collaborative care team, right? So that the primary care provider can be getting interpretable information back about the progress and the needs of the family. Noticing a chat, just wanted to, yes. So Cindy makes a great question about suicide-specific screening tools. And yes, the Columbia is a great tool. There are other tools. We have yet to specify that because we're working on FAST-S and trying to determine how best to sort of link those up. And I think we have a team of experts and they have opinions that we want to incorporate into that. But yes, I would definitely encourage that. And also, tools like the PHQ-9 can be a place where you can begin to sort of assess suicidality as part of your screening. Okay, so maybe we'll have time to return to that, but I will plunge on because I think you'll be interested to see these tools if we have time. Okay, so you might look at these problems, you see these neat little boxes and acronyms, and it seems like we're saying, oh, you could treat anxiety, or you could treat depression, or you could treat trauma, or you could treat behavior problems, right? And are we maybe sort of forgetting the fact that these are highly overlapping areas of concern, often sort of relating to each other, feeding into each other, and happening in the context of complex environments, oftentimes with lots of adversity. So we're really very much aware of that. We haven't designed these because we think these are discrete concerns. And in fact, we've tried to design them to be wide funnels to really receive kids with overlapping needs and concerns. But we think that by training providers to identify and prioritize a target, that's really appropriate to this, to efficient care. That if we're going to offer a stepped care and do a first pass that's efficient, that we want to pick something that we think we can treat, and also that hopefully we can identify something that's the driver, right? That is the core concern. So for example, oftentimes with anxiety and depression, it's anxiety that's interfering and causing so much interference with life and functioning that depression is secondary. In that case, we encourage folks to treat the anxiety, right? That's going to be our best sort of intervention. And the truth is that many providers who are using the FAST programs, because they're modular, they're flexible, they have tools that you can use as a handout here and there, they are using some of both. They're pulling a little of this, a little of that in ways that that match the needs of the families in front of them. And of course, things like FAST-P and FAST-B, which teaches core evidence-based parenting skills, are useful across diagnostic categories, right? They're inherently transdiagnostic, though we do emphasize those when there's externalizing concerns. Okay, so again, this is really a way to have focused treatment and to have efficiency and potency, ideally, by focusing on these. And if you have the resources to use more than one program, you could use them in combination or in serial. And again, we're pretty flexible about how that should look. And the other thing to say is we don't expect that every kid is going to need one of these programs, right? Some kids may come to you and they're voicing a need that is separate, right? Or maybe they have some challenge that they're facing that you can directly address with the kid and or the family, or do some problem solving. Or maybe there's some environmental challenge that you can help the youth manage, right? Maybe you partner with the school in some way, or you advocate, or you do some other intervention. So we don't want to encourage you to sort of shove kids into one of these programs or to use them rigidly, but to consider these as ways that you can begin to address these really, really common concerns in ways that are informed by evidence and hopefully user-friendly for a primary care setting. Okay, so let's spend a little bit of time showing you things from the programs. And I want to start with anxiety. And as I mentioned, it's adaptable to a broad age range. It's for concerns like kids who are avoiding or dreading normal situations, excessive worry that's getting in the way, or stress-related somatic complaints, right? Where they're having headaches or stomach aches that seem to be related to stress or anxiety. And the key components are to help the youth and the family understand what anxiety is, how it shows up for them, and ideally come to see it, as less threatening and more of a resource. And also, to use brave practice or exposure to help them overcome fears, right? To sort of face fears and in that way, train their brain and body to have less of an intense distress or fear reaction to those situations that don't need to be threatening. And recognizing that for some youth, they may need to build new skills for the situation that they're anxious about in order to be successful. They may need to make some plans to deal with a real stressor or a realistic fear that relates to something going on for them. Or we may need to change the environment, right? Sometimes anxious kids may be having bullying going on, and then we need to do something environmental, or increase supervision, or do something at the school. So really just highlighting that brave practice or exposure is kind of the key strategy, but that also there's flexibility within the program to receive the kids and the concerns that they have. Okay, so I want to share the 2-pager for FAST anxiety. We're just going to be doing like a tour of a whirlwind tour of a handful of the things that we have. I'm not going to show you everything, of course, from FAST anxiety, though you can see just about everything by watching one of the on-demand videos if you're interested. Okay, So this is the two-pager that we recommend for primary care providers to use and for behavioral health providers to use, and maybe other staff. And you can see very quickly that there's a lot on here, right? A primary care provider is not going to have time to read through this whole handout with a family. We know that. And yet, what we've tried to prioritize, again, is to have actionable strategies that families can actually go and do something about, right? It's not a generic, here's a diagnosis, here's how we define it. You may have a chemical imbalance and you should seek treatment or medication, right? This goes well beyond that and gives families actionable behavioral strategies that they can use. And while there is a lot, and there may be a fair number of words or density to this, we feel pretty good about having condensed what could be a 300-page self-help book for parents into a two-pager that they can read and understand and use. So what I'll do is I'm going to just sort of highlight the things that are on here, and you can think about, and then maybe afterwards share in the chat ways that you think this could be helpful in your setting, in your workflow. How might you use this? If it's to go through it entirely with a family, or to reference it or give it out, or in some other way. Okay, so for all of our two-pagers, we have a quick summary at the top, which includes things like what is anxiety, when's it a problem, what leads to high anxiety, how can kids and teens overcome high anxiety when it's getting in the way. And the answer is that the way to lower anxiety about normal situations is to face those situations. Some youth may need to learn new skills, like what to say or do to be successful with their feared situations. And this is often also called exposures or brave practice. And what we know from the latest research is the way that exposure works is that it helps disconfirm our fears. So youth will learn that what they fear is actually not so likely as they thought from experience. They will learn that maybe it's not so dangerous as they thought, or that it's something they can handle. And so this experiential learning is the most rapid way to help kids feel less distressed, less anxious, and better able to function in the presence of their anxiety. Okay, so a word here about accommodation. So there's been a lot of cool research on this topic. The accommodation refers to when parents or caregivers help kids avoid the normal, safe situations that they're afraid of. And helping kids avoid their fears is understandable because it helps. It's hard to see kids get anxious, and anxious kids are often acting up when they're anxious. And accommodation sometimes helps kids to function better, right? They may go to a birthday party they're nervous about if you stay there with them, even if you're the only parent there, right? So we know that accommodation makes sense, it's understandable, but over time, research shows that it tends to make anxiety worse, or it prevents kids from getting over it because they don't get this new learning that in fact, their fears are unlikely to come true, or that they can handle anxious feelings in hard situations. So we also include some common traps that parents fall into, things like rescuing, avoiding, giving too much reassurance, overprotecting, or things like shaming or yelling at your kid out of frustration. So the second page is more about the action steps. And at the top is a little bit of a sort of a worksheet space where parents can identify what are the situations your kid's anxious about that you most want to help them be more comfortable in and be able to face. And then generate some steps that your teen or child could take, right? Some easier and some harder steps. And then identify some rewards that you can give your child to help them, motivate them, and help reward them for the hard work of facing fears. And then encouragement to face fears more than once so that the learning really sinks in, right? These processes that we know are part of helping kids overcome anxiety, which is to learn that their fears aren't so likely, it's not so dangerous, and it's something they can handle. And that confidence will grow and anxiety decreases with more practice. At the bottom, we talk about the to-dos, the things that parents can do: validate, encourage with confidence, ask questions to highlight the new learning, right? What did you learn? How was this different from what you feared? Reward that brave behavior, model facing fears of your own, face fears with your kid. And then this is a big one. As caregivers, we are programmed, right, through evolution, really, to rescue our kids, right? They express distress and fear when they're in danger. And because they're young and they can't sort of defend themselves against danger, we need to respond to that and save them. But in the case of elevated anxiety, right, when it's getting in the way, chances are that distress is being expressed when maybe you don't have to rescue them. So sort of arming parents with the resolve and the understanding that this helping avoid them, their fears, is not helpful in the long run. And then, expect anxiety. That's part of a brave practice. You can build up to start with easier things. You should keep practicing, do it daily if you can, and use rewards to motivate. So, and then at the bottom, ask your primary care provider about finding a local mental health expert. So that was a lot of detail. And again, more than would ever occur in a primary care well child visit. But I'm curious, and I want to see in the chat if you have thoughts, and some of you here attending may actually be in clinics using the FAST programs. I think I may have seen some faces or some names. So share in the chat if you have thoughts about how this could be useful to you, how you might use it. And I know there's quite a bit of behavioral health providers I saw. So maybe you have thoughts about how this tool could be useful. Not seeing lots of chats yet. Okay, well, I'm going to keep going, but please filter your ideas in there, or at least just think internally and reflect about how this might be useful to you, since it's free. Okay. I also want to show you now. Oh, great, we're getting a chat. Oh, great. So we're hearing some good feedback from Heidi Williams. Thank you. The handouts are at the website, and you can see the website on our slides, and we'll show that repeatedly as we go. You can find that. Oh, great. Thanks, Erin. That's our website, and you can find our 2-pagers there. And these are really potentially useful, I think, when you can't get access. So I know there's some folks here from community mental health agencies, and I know that some of those agencies are giving these handouts to families who are on their wait list as a compassionate way to help them bridge that time until they can get more support. Okay, great. So I'm going to pull up, not that, I'm going to pull up now the FAST-D. So I want to show you, okay, I guess I'll show you the slide. Okay, so the FAST depression program, you can see kind of who it's geared to, right? It's geared mostly to teens. We do provide some guidance in our trainings and materials related to depression in younger kids, but we know that the prevalence is higher in teens, and our workbook and materials are more geared towards teens than younger kids. And I want to sort of quickly, because of time, I want to just showcase a few things from the FAST-D workbook, because I want you to get a feeling for how we've tried to design these tools. Okay, so hopefully you can see the workbook. On the front, there's a little illustration usually, or a picture, and I include a little bit on the front that just says who it's for. I do highlight that safety concerns, there are some safety resources included in the FAST-D program, but it's not designed for kids who have acute suicidality, who have self-injury. We do encourage that to be the treatment focus really completely if it's present, and then maybe you move on to FAST-D type activities when you have resolved or managed those concerns. And then also, as I was saying, anxiety often drives depression, and we encourage you to use fast anxiety strategies to deal with anxiety if it's present and it seems to be a driver. And then post-traumatic stress, oftentimes traumatic events are a key driver or predictor of depression. And when that's a driver, we think that some specific attention to that could be helpful. And this comes partly from our research that we know that treatment for depression tends to be less effective than some of these other treatments, and that other treatments can also have benefits for depression symptoms. So we do encourage that. And we always plug in our brief treatments. We don't want people to feel like they fail a treatment. So we highlight that sometimes more support is going to be needed, and that's okay, and that's normal. Okay, so I'm going to skip right through here. I want to show you just little bits and pieces. First, I want to show you in the first session, or maybe the second session, depending on how quickly you're moving, there's a treatment menu in the FAST-D program. And I want to just highlight how flexible this is. In part, we know that depression, there's many pathways in, and many pathways that potentially could help people out. And so we try to create a really flexible approach to this so that you can adapt it to the needs of the kid in front of you. So here are 6 things we could choose to focus on in our future meetings. And we likely won't get to all of them. And this would be a place where hopefully you've shared if you have parameters like we can only meet 6 times, or we meet 8 times, or that this is a brief treatment. And some of these might not really apply to you or your situation. And we can decide together what feels most important. But it's usually a good idea to start with the first 2 because they can have such a big impact on depression. So let's take a look at the different components of FAST-D. The first is a body boost. And this is where you spend a week really doing an experiment. You focus on changing sleep patterns to be more healthy and try to get a little bit of physical activity every day if you can. And of course, we work with where teens are, but what we can see is that if you don't work on sleep in the beginning, and a teen is, they get home from school and their sleep disruption is such that they are too tired after school and they just want to take a nap, you're going to really struggle, right? Or if they're not sleeping at night and then they're sleeping in the morning, you're going to really struggle to get them to follow through on the activation plans or strategies that you've come up with. So we focus on sleep first and find that that really helps us with the next steps. Though again, we're flexible because maybe the teen who comes in just has a major problem that seems to be really driving things for them. You can focus there if that seems important. So the second thing is change your moods. This is where we teach about how you can use behavior to change your mood and talk strategically about how you do that. Make my life better involves a section where you invite teens to reflect on what they'd like to be different in the different domains of their life and pick something that they'd like to change, and then make a really concrete, doable plan to begin working on that week. Problem solving is this one, right? There may be something stressing the teen out that's contributing to their depression. Learn better ways to cope begins with exploring, how do teens cope now? Are there ways that are healthy? Are there ways that are okay? Are there ways that maybe aren't such healthy ways to cope? And then exploring a menu of strategies that could maybe be useful, and actually trying out some coping skills together, and then making a plan for using them in the times when they might be needed this week. And then fix my parents is intentionally phrased in a provocative way to engage teens, but this gets at the fact that oftentimes problematic interactions with parents are common in depression, and teens oftentimes, sometimes rightly, will point to their parents as saying this, they're doing some things that are contributing to my mood problems. And so this is a place to respectfully help teens come up with a game plan to address these things. And there is also built in a parent component where we talk about parent support strategies with parents, and that happens usually within the first couple of sessions as well. So that just gives you a sense, hopefully, of the flexibility in what we cover. And I just want to quickly, because I want to preserve as much time as I can for Erin to show some of the tools that she plans to show, I want to show you the Change My Moods module to give you a sense of what this might look like, and hopefully how easy to use it is. So this is where you learn tricks to get unstuck from bad moods. And a lot of us don't feel like doing much when we're down or depressed. You can just read this with families. Our mood's kind of like wearing sad glasses. Nothing looks very fun or appealing. It can feel easier to be alone or distract ourselves in ways that don't really make things better. And this can lead to a downward spiral of our mood. Maybe we start out meh and we end up kind of bleh, right? Things may be getting worse or not better. But if we can get ourselves active, we can often get ourselves out of a funk. We can boost our mood or energy levels just enough to get in an upward spiral to a better headspace. So this is where you do an experiment. So you have the youth rate their energy and their mood from 1 to 10. You pick a quick mood boost that here are some ideas you can try. And then you rate your mood and energy again. And typically it's different, right? With some of these mood boosters. And do we think that this is going to solve depression, particularly for kids who have really challenging circumstances? No, not at all. But hopefully it can be a tool, right? This can be something that will help youth. Maybe they're feeling really tired and they've got to do their homework, but they're almost asleep, right? They can energize themselves, or they've got to, get up and go somewhere or do something. They can use a mood booster to help them. So in this session, there's an optional worksheet here, but what we encourage for all of these, we try to make them adaptive. So if you've got really brief settings or you're running out of time, you skip this page and you go to the most important thing, which is you make a plan for how you're going to use a mood boost this week, right? How you're going to implement this strategy. But if you have time, this is an activity to generate some ideas. So, spend a few minutes brainstorming different mood boosting activities using this menu. You can do this together or as a homework for the next meeting. Feel free to include parents or caregivers if that feels helpful. And you can see the menu includes starters. These are quick and easy activities just to boost your mood and energy. Really easy to do. Mains, these are activities that may take more effort, but they're rewarding. Things like maybe practicing an instrument might go here, right? Because probably it's not going to be great. It may sound crummy, but overall it's rewarding and it leads to maybe a good feeling or good outcomes. More rewarding life. Sides, these may be pick-me-ups you can add to your daily routine. So particularly for teens who need it, maybe adding walking home from school with a friend, or building in a carpool, or something that you can do just to sort of build activation right into their routine so it's automatic, right? That can help a lot of people. And then desserts. These are things that are fun, but not super healthy. Things like playing video games alone. You can consider these like using rewards for doing things that are hard, like homework or exercise, right? So this just gets them to begin brainstorming how they can use activities or behavior to change their mood or help them out. And on the right, we talk about what research says tends to work best. Oh my goodness. How did I use up all this time? Okay. So you can see that there, and you can see ways to implement this. So let me stop sharing and turn it over to Erin.
All right, great. So I'm going to talk about the FAST Behavior and FAST Parenting Teens programs. These are transdiagnostic, so they're not focused on a single diagnosis or even one single presenting problem, more like the anxiety and depression programs. They're pretty broadly focused on just challenging behaviors and family relationship issues. So FASB, this is a great program for kids who do have a diagnosis of ODD or ADHD, but also just kids who are having tantrums, some oppositional behavior, or maybe the caregiver is just really struggling, overwhelmed, stressed, and needing some different strategies. So we were a little surprised in the initial pilot how many referrals we were able to get of families in primary care who really were needing this type of intervention. So this program is a boiled down version of parent behavior management training, a very well validated, well studied, evidence-based treatment for ADHD and disruptive behaviors. And we've boiled down to kind of 4 key components. And so we're boosting the foundation, the parent-child relationship first, trying to increase the amount of positive interactions, and then differential attention. So we're trying to give lots more attention to the positive, encourage that, get kids to work for positive attention, and reduce attention to negative behaviors and things that are provocative or designed to get a reaction. And then we have some modules on having clear boundaries and giving rewards in an effective way, an immediate way that's meaningful for the child and easy to implement. And then consequences, we talk about removing privileges and timeout. There's also some bonus material on dealing with screens. Even in the 5 or so years that we've been running these programs, we see more and more families whose top concern is, how do I deal with screens in the household? My kid turns into a monster when I let him watch on the iPad. And so we're finding that can be a really valuable use of session time as well. I want to just give a little overview of how both of these programs aim to change the family cycle. We're intervening with parents, caregivers, rather than the child directly. Sometimes that can be a tough sell for families. They came in thinking they were going to get therapy for their child, but we don't find, especially with younger kids, that is the most appropriate or evidence-based way to help with ADHD or challenging behaviors. And here's why. So if maybe we've got some inherent challenges that the child's having with self-regulating, being impulsive, or being distractible. And in turn, parents have to do a lot more work than other parents are doing, right? They're having to correct and redirect more, and they're not able to be consistent because the behavior is more challenging. Then in response to this kind of over-parenting, kids start to get frustrated, right? They may dig their heels in. They're getting so many commands. How can they possibly keep up? They may intentionally not follow directions, or they may do things designed to kind of get a reaction or get more attention. And now parents start to become even more stressed, right? They feel overwhelmed. They feel kind of pessimistic about the outlook on their parenting, and start to have negative expectations for their child. And this only worsens the cycle for kids, right? And maybe now, instead of just some dysregulation and attention problems, now the child is starting to have more explosive behavior. And we're dealing with a comorbid externalizing problem, or they're kind of turning on themselves a little bit. Their self-esteem is affected, or they're having anxiety, or they're having low mood because of all this environmental stress that's kind of compounding in different settings. And now parenting is really hard. It was hard all along, but now it's fine. Parents are finding it to be even less effective. They tend to be giving up more, not holding boundaries because it's too punishing for them. or just withdrawing and not trying to have fun time together. Nobody's enjoying the relationship because it's so tense. And so this is a cycle that repeats itself, certainly, and it gets ingrained over time by the time parents come to see us. I'm wondering if this is sounding familiar for clinicians who are working with parents of young kids or teenagers, really. So how do we untangle that? Our programs, Fast B and Fast P, both try to help with some positive parenting skills. So parents have a game plan of how they're going to react to things, how to encourage positive behavior. The child then has more success experiences and they feel motivated to seek positive attention because that felt really good. That actually was more rewarding than the negative attention. And they also know what's expected of them. Parents can drop the rope on some of the power struggle and pick the battles that are really most important and respond calmly to behavior. And again, kids then have more positive to build on and feel good about. And in the end, the family's having more fun together and everybody is more motivated to try to make each other happy and make things go well. And so the cycle is hopefully broken. So I'm just going to flash up here. Let me stop the share and switch to the 2-pager. Sorry, I have so many screens open here. I'm not going to go through this in great depth, but just wanted to show you an idea of how you might use this tool briefly. Hopefully this is it. Is that the 2-pager? Hopefully, yeah. Okay, great. So you can see there's some psychoeducation here about how behavior problems start to involve the entire family, even if maybe it started with the child, maybe, but everybody gets pulled in and parents are kind of the key to helping to undo that cycle. It's not developmentally appropriate to expect children to just through sheer willpower stop engaging in negative attention-seeking behaviors. So we try to look at ways that maybe parents are falling into traps. And then this 2-pager allows them to set some small goals related to positive attention or ignoring, and some more tips here. I'm not going to go through it, but I would encourage you, you can go on the website even right now and download that if you think that would be useful. I do want to show real quickly, we're almost out of time, but I wanted to, I thought it might be useful to show a quick video so that you can get a feel for what it is like to do this type of session with a family via telehealth. So let me try to play this. Oops, I'm sorry. That's not what I wanted. Here we go. Okay. Let me expand it. Sorry, everyone. Okay. And then there's another. Oops. So this is me working with a dad of a 5-year-old girl and teaching special time. We have just done a role play where his daughter likes to play with little figures like Peppa Pig. And so we had me be the parent and him be the kid, and we did some demonstration. And now he's being the parent and I'm pretending to be his daughter. And you'll see how we kind of pivot that back into the workbook handouts.
I'm seeing that.
Oops.
I know. Careful not to walk too hard.
Here we go.
I know. I don't want to break them.
Yeah.
Okay, we're at the ball now and we're dancing.
All right. So wow, those are really cool moves. I didn't know you can dance that well with glass shoes.
Love it. Okay, let's pause there. That was awesome. This is weird to do, right? How did that feel?
Yeah, it's weird to not ask questions. And it's very weird to be describing what you're seeing or pretending you're seeing. But yeah, it does work nice for kids to just use their imagination.
Yeah, okay, so you saw, even though it felt pretty different, you saw some benefit there.
Yeah.
How do you think Amelia would respond to this?
Yeah, I think she would have a lot of ideas and just proposals of what next to play with and what to do next. So I think she would love it.
Super. Okay, that's great. All right, the last thing I'm just going to show you for today is this handout number 3, which talks about what is special time. And we already covered, I want to encourage you to do this at least 5 days this week, letting her pick and just praising, ignoring any annoying things. Sounds like she's probably not going to push it too much, but and doing your attending it without questions or instructions. And then if you get stuck, there's a few ideas here of special time activities. Do you think Amelia's going to have any trouble thinking of things?
Oh,
no, okay.
No, she will have a lot of ideas.
Okay, got it. We do want to avoid video games and screens, because that is not an activity, right? We want something that's interactive. And just avoiding things that are super competitive if that's going to create conflict for her, or things where we have to do a lot of teaching. I know you mentioned that Amelia's learning chess. You guys are playing chess together.
Yeah.
So that could be great, but we don't want it to turn into too much instruction. So if she wanted to invent a way of doing it herself, for 15 minutes a day, we want to just let her run with it, even if it's not the right way, quote unquote. So that could be something, as long as it's
Okay. I hope people were able to see that. That's a video that actually you can watch the full thing. It's about 18 minutes long. It's going to be up on our website soon. So I'm hoping that gave you a taste of what it might look like to do this type of session with families for those clinicians out there. Real briefly, I want to just tell you what is FAST-P. Sorry, again, too many screens open here. All right, current slide. This is the current newest program we have. FAST-T will soon be the newest, but this is similar principles, but just aged up for older teens. This program is focused a little bit more on communication. So this is great for teens who are getting their own therapy already, or if the teen doesn't want to participate, or if the primary stress is that the parents are really struggling with that relationship. So it's great for dealing with emotional escalations. The teen may have an anxiety or depression related problem. This is still a great complement. And so we're focusing on emotion validation, teaching parents how to listen and diffuse conflict, and setting reasonable expectations, especially around schoolwork and screens in the home. And there's some bonus material that we just added related to aggressive behavior from teenagers, because we were hearing from our community partners that they are seeing some teenage behavior get really out of control and threatening and even dangerous. And then I'll just leave you with the image of the FAST-P 2-pager. Here we go. Which talks kind of, first about all the different things that affect teen behavior, traps that parents fall into with teenagers, and then again, some ways to set some simple limits, but clear limits, but also make things more positive and pick fewer battles at home. And here's the workbook. I just wanted to show this is the table of contents. Some of the different modules you can use. There are 4 themes. The last one is making a plan around either schoolwork issues or screen issues at home. And then some bonus handouts related to ADHD. This is really a program based on evidence-based parent training for teens with ADHD. So it's great for parents of teens with that diagnosis. And then the crisis plan at the end for aggression. I was just going to flash down to show you what some of that looks like. There's some parent coping in here as well. Here's, for example, here's a handout on teens and screens for parents. FAST-D has some teens and screens materials for the teenagers, and creating a family media plan at home. There's a similar version to this in FAST-B, and an example of a cell phone contract that parents might use. And then here's our crisis plan. So dealing with really threatening behaviors at home. All right, so let me, on a final note here, just end with what you can do next if these resources sound useful for your clinic, you want to learn more. As Nat mentioned, everything is available on our website, including the videos. And reach out to us if you're interested in live trainings. We're planning to offer some in early 2022. We have a training for each program that we'll offer, as well as Fast T for the first time. So you can reach us at fast@seattlechildrens.org. Happy to field questions, set up a call to talk more about trainings, and set you up with our weekly consultation calls. Nat and I run these calls every other week. And again, we have clinicians that have been on them for years, and also new folks. So you're welcome, if you want to use FAST and get trained in FAST, to join those calls to keep refining how you're using it. And also, we're learning from these calls also as you tell us what's working and not working in your primary care setting. And just want to end noting limitations. So we are still conducting more research on these programs. They're relatively new in the scheme of things, especially the versions that are specifically tailored to be done in a primary care setting. There is some, they're specific, they're not completely broad. They may feel diagnostically bound, although we, as Nat talked about, we have reasons for why we've gone that route, and we do think it is helpful and effective for the kinds of families and kids that are being seen in primary care. And we do also think it's very helpful to get some ongoing consultation. That's not required. You can use the materials, but we're finding that seems to help the most with the nuances and working out the kinks of how to use it. And of course, social determinants of health are super important to consider when we're trying to understand mental health concerns for kids and families. These programs are not specifically targeting SDOH, but there are some great tools out there, such as the SEEK screener and program, that focus more on targeting those types of stressors and concerns, or problem-solving programs that already exist may be good starts if you think that that would be the most appropriate approach for a particular child or family. Okay, I'm going to stop and see what we have for Q&A.
And before we jump in, so we're going to transition briefly to Q&A, and I know that we're almost at time. And I don't know, Erin, if you're also able to stay a few minutes afterward. I know Nat is able to. So if folks have additional questions, we will hang on to the call a little bit after 2:30 just to make sure we answer all of your questions sufficiently. And so I know that Nat was answering some of the questions in the chat. But to kind of start us off with Q&A, Cindy had asked, or had said in the Q&A box, I think it would help boost outcomes for the clinician to do some brief motivational interviewing prior to starting to use the FAST modules with patients. If a patient is in the action stage of change, they're more likely to see better results using the modules. And then Cindy also asked, what are your thoughts regarding FAST compatible motivational strategies? So Erin, Nat, if you wanted to start by maybe expanding a little bit on that. I know that you've started to answer it in the chat, but if you have any additional thoughts you want to share with us.
Yeah, thank you. And I'll start because I know Erin had less time to digest the question. But I think my initial answer to Cindy was that I totally agree. And I think that motivational strategies are wonderful, and being attentive to that aspect of where people are at when they show up is important. I think we've built into our trainings and materials some motivational aspects, right? We've tried to invite, we try to ask, our worksheets and activities have posed questions and tried to elicit goals and motivations in ways that we think can help build motivation. And some of the programs are really designed to meet the teen with whatever their goals are, right? So the depression program is really designed to help them with their goals if that's what they want. So it's not hard to align with something. And all of the programs involve caregiver support and the potential for caregiver motivation. So if a youth is not motivated to make change, the parents are empowered with support strategies, their own sort of interventions, as well as motivational strategies like incentives, especially in the behavior sort of category. So there are times where, for example, in the when it's clear that a parent intervention is needed for disruptive behavior, sometimes we have a motivational interview or a motivational issue there with parents wanting to be the target of the intervention. And Erin has so thoughtfully crafted the materials as well as the training to help providers sort of manage that expectation and receive those understandable concerns and preferences while also building their motivation to try some new things. So Erin, I don't know if you have additional thoughts about motivation and how that, whether there's need for additional skills or how we've built that into what we recommend to providers and clinics.
Yeah, absolutely. I mean, motivational interviewing, I use it a little bit in every session I do, always. So it's certainly compatible. In, for example, the FAST-B program, there's a manual. We kind of moved away from the manual approach, but there are a lot of kind of common barriers and common concerns that parents bring up about participating. And so we talk about some MI strategies there. But certainly it's something, good thing for Nat and I to keep thinking about. How do we make sure that clinicians are supported adequately to deal with barriers and just get people started with their goals?
Cindy, does that help? I don't know if you have more thoughts or questions on the topic, since I don't see that we have a ton of other questions, though there are some questions I tried to answer in the Q&A, so people can look there and we can also expand on some of those answers. Okay, sounds like Cindy is finding those answers to help. Feel free to add more if there is more that you want to say. Other questions people have? Ooh, did we get an, oh no, that's Cindy.
Kate's question. I think you've answered
Yes.
that.
So Kate had a great question about FAST programs being evidence-based. I think, as Erin mentioned, there is still more research to do. I think depending on how you define evidence-based, you will say that maybe FAST programs need a lot more research to clarify through randomized control trials, et cetera, that in the various flexible formats that they're delivered, that they would work. And I think, one challenge in testing them is that we encourage people to use them in ways that are adapted to their settings. And so we would have to do the trial probably in many different ways at this point to verify that the ways they're being used are helpful. But the thing that I can say is that there are in Washington State expectations that if you're going to be billing for certain evidence-based treatments, that you are delivering certain kinds of components. And we've made these programs to be consistent with those. So if you're doing CBT for anxiety, for example, and you want to bill under that category as a CPT code, there's an evidence-based reporting guide that would show that you're being consistent, right? So if you're doing FAST-A, you're being incredibly consistent with that, and you would qualify for using that billing code. And the same is true for the other programs in the ways that I've written. Oh, Sarah responded. Hopefully she doesn't disagree with me. Okay. Okay, yes. All right, so, good point. So as Sarah's pointing out, the reporting guides not only specify what components you use, but there is a requirement that you be trained. And so I think therein lies a little bit of fuzziness, because anyone could say they're doing the treatment, but if they haven't been trained, the entities that are paying for the services may not want to pay you as though you have been trained. And FAST has its own unique training approach, which for some people involves watching the videos and running with the materials without further training. And so if you're one of those providers, there's a question. And then our other training approach is also fairly abbreviated. So I think we need to talk, with EBPI a little bit further to see what certification might be necessary before you could potentially use those codes. So, okay, maybe I have a caveat to my answer, which is that as far as the reporting guide's concerned, if you haven't received formal training such as CBT Plus, then you may or may not be able to use those codes. And maybe you should follow up with us and or EBPI to verify that. Was that confusing? Did that make sense, Erin? Okay. Okay, Kate seems to understand. That's what's most important. Other questions? We're thrilled to be here in this conversation. As you can tell, we're very receptive, and we have lots of conversations in which we get constructive feedback and then turn it right around and put it into the materials. So hopefully you've seen that this is collaboration, and one in which we are always looking for new partners. So glad to be having that happening today.
Right. Again, please be sure to email us, and we'd love to even hear just comments, other things in the chat that you'd love us to make or consider. We do certainly, we're always looking for ways to improve and expand. So if you have things that you're seeing in your clinic that you'd love some tools for, we'd love to talk about it.
And I would also add, if you have thoughts later on, feel free to add those into our post-webinar survey. So all the panelists will receive that information, and CoLab and EVPI will also be kind of synthesizing those and moving forward with that information to improve our webinars. So I think with that, unless we have any final questions, we will wrap up the webinar for today. And thank you, Joanne, for putting that in the chat. Oh, I'm seeing a quick question from Gloria about the, I think, CME training or CME credits. So Gloria, you can definitely reach out to us at uwcolab@uw.edu if you have any kind of further questions. But I believe you just self-report on AAFP's website for the CME credits. And if not, if you don't typically report to them, you can also reach out to whoever your organization or entity is that you usually report CMEs to, and just check in with them about that process. We're also happy to send kind of a certificate of completion if that's helpful for you. But feel free to email us if you have any questions. Happy to troubleshoot with you. And I believe Aaron and Nat have definitely said yes to the slides. So I think, Cindy, if you want to just, if you're able to privately tap me your email, or if you just want to email us again at uwcolab@uw.edu, we can then respond with the slide deck. So absolutely. And that goes for everyone. So yeah, so I think in the interest of time and respect for your Friday, we will close out for today. So thank you so much again to our wonderful presenters, Aaron and Nat. This has been an incredible and informative presentation. So we're just so appreciative of your time and your sharing your expertise. So again, as a reminder for all of our participants, feel free to check out parts 1 and 2 if you missed them of this webinar series, which are also really helpful and informative on other aspects of pediatric integrated care. And those are on our website, uwcolab.org. And as a reminder, again, feel free to reach out to us with any additional questions, and don't forget to fill out the post-webinar survey. So thanks again, Nat and Aaron, and hope everyone has a wonderful weekend.